It's my honor to introduce our study. I'm Chen Siyu from Affiliated Hospital of Jiangnan University. The title of our study is Synthetic MRI combined with Clinicopathological characteristics for pretreatment prediction of Chemoradiotherapy response in advanced Nasopharyngeal carcinoma. Nasopharyngeal carcinoma is a prevalent malignant head and neck tumor. Owing to its deep position and asymptomatic nature, most patients are diagnosed at advanced stages. While chemoradiotherapy is effective, some patients experience local residual disease and relapse. Therefore, it would be valuable to identify patients with CRT-insensitive ANPC before treatment. MRI is crucial for assessing treatment efficacy, but it also has some limitations. Therefore, a more effective MRI technique is necessary for the pretreatment prediction of CRT response in ANPC. Longitudinal relaxation time, transverse relaxation time, and proton density are inherent and independent features of tissues in MRI that can reflect microstructural changes within lesions. Synthetic MRI provides T1, T2, and PD maps after one acquisition scan. It has been used in many ways. However, the clinical value of synthetic MRI for the pretreatment prediction of CRT response in ANPC remains unclear. The objective of our study is to explore the potential use of quantitative parameters from SyMRI and DWI for the pretreatment prediction of CRT response in ANPC. Second, incorporate the SyMRI parameters and the clinical pathological characteristics into a multivariable model to evaluate the performance of CRT response prediction in ANPC. For about 2 years, 155 consecutive patients with biopsy-confirmed ANPC were enrolled. The flowchart of patient selection is shown in Figure 1. Data on clinical factors were collected for all patients with ANPC. In the week before and 1 month after CRT, all patients underwent MRI examinations using a 3T MRI system with a 28-channel phased array coil. Part 2 shows the specific parameters involved in the study. All MRI images were independently analyzed by 2 radiologists who were blind to the reports. The static MRI data were transferred into post-processing software. The region of interest was manually drawn along the contour of the tumor on the slice with the largest tumor diameter on synthetic T2 weight image, with reference to CET1 weight image to avoid obvious necrotic or cystic regions and peritumor edema. The presence of external extension, tumor volume, tumor stage, and tumor size were assessed by a radiologist with 11 years of clinical experience who was blinded to the clinical and histopathological data. All patients received 2-cycle induction chemotherapy. 2 weeks after induction chemotherapy, all patients received concurrent CRT and 2 cycles of chemotherapy. MRI analyzed by 2 radiologists 1 month after CRT completion. CRT response graded based on the RECIST version 1.1 standard. It is shown in Part 2. Patients with complete response and partial response were categorized into the response group, and others were categorized into the non-response group. Here are the statistical analyses we used in this study. All analyses performed using Medcalc and SPARS. Now let's turn to the results. This study involved 127 patients with ANPC. As shown in Table 1, there were significant differences between the RG and the NRG in terms of EBV DNA levels, ENE, clinical stage, and Ki67 expression. Compared with RG, NRG had significantly lower T1, T2, and PD values, whereas there was no significant difference in AD values. In comparison with post-treatment lesions, pre-treatment lesions had significantly lower T1, T2, and PD values. Here are some representative cases. The figure shows a 50-year-old male patient with ANPC and stable disease in the NRG. In comparison with RG, relaxation maps showed significantly lower T1, T2, and PD values, whereas there was no significant differences in ADC values between RG and NRG. And this figure shows a representative 46-year-old female patient with ANPC with completely response in the RG. In comparison with the NRG, the relaxation maps showed significantly higher T1, T2, and PD values. CET1 weight image demonstrated that the tumor was 26.74 mm in diameter before CRT. After CRT, it shows that the tumor has almost disappeared. As summarized in Table 3, T1, PD, EBV DNA level, clinical stage, and Ki67 expression had significant independent relationships with CRT response in the multivariable logistic regression analysis. As shown in this page, the AUCs for T1 and PD were significantly higher than those for T2, whereas no significant difference was found between the AUCs for T1 and PD. A multivariable model incorporating all independent predictive factors showed excellent predictive performance for CRT response in patients with ANPC. This study investigated synthetic MRI parameters and clinical pathological characteristics in CRT response prediction for ANPC patients. NRG synthetic MRI parameters lower than RG. Multivariable model showed excellent performance. Clinical stage, Ki67 expression, EBV DNA level, and ENE may be useful factors for predicting CRT response in ANPC because advanced stage tumors and those with high cell proliferation may often be accompanied by necrosis due to ischemia and hypocresia. The T1, T2 value in the NRG was significantly lower than that in the RG because hypocresic tumors can decrease T1, T2 values. The PD value was significantly lower in the NRG than in the RG. The multivariable model incorporating synthetic MRI parameters and clinical pathological factors further improved predictive performance, and ADC values were no significant difference between the NRG and RG. This study also has some limitations. First, this retrospective study was conducted at a single center and involved a small sample of patients with ANPC. Therefore, a multi-center study with a large cohort of patients with ANPC is required to validate the generalizability and clinical implications of this study. Second, RECIST was used as the gold standard for evaluating the treatment response to CRT, which should be verified by tissue diagnosis in future studies. Third, the single-slice measurement of synthetic MRI parameters may be influenced by the reader and may only represent a portion of the tumor. Whole tumor measurement more accurately reflects overall tumor characteristics and allows for the assessment of tumor heterogeneity, which should be performed in future studies. Fourth, this study lacks external validation. Fifth, ENE was assessed via imaging in this study, which is less accurate than pathological assessment for predicting outcomes in head and neck cancer. In conclusion, synthetic MRI quantitative parameters were useful for the pretreatment prediction of CRT response in patients with ANPC. The multivariable model incorporating synthetic MRI parameters and clinical pathological factors, which were independently associated with CRT response, may serve as a new tool for the pretreatment prediction of CRT response. Thanks for your listening.